Hello, my name is Samantha Liu, and I am here to discuss a study of access to sex education and receipt of government assistance. To begin, my research question is, does exposure to comprehensive sexuality education decrease a woman's likelihood of receiving financial assistance from government programs, excluding student loans? The Sexuality Information and Education Council of the United States, other known as SICUS, defines comprehensive sexuality education as programs that include age-appropriate, medically accurate information on a broad set of topics related to sexuality, including human development, relationships, decision-making, abstinence, contraception, and disease prevention. Abstinence-based programs may also contain age-appropriate and medically accurate information, but they highly emphasize the importance of abstinence. Abstinence only and abstinence only until marriage not only emphasize the importance of abstinence, but they also do not teach about contraception or disease-preventing methods. Fear-based programs intend to control young people's sexual behavior by instilling fear, shame, and guilt. This may be done through negative messages about sexuality or distorted information about condoms and STDs. To answer my research question, I decided to use the system reform theory, which is the theory that system policy changes address social welfare concerns. In order to test my theory, I developed the hypothesis that comprehensive sex education leads to lower rates of welfare receipt. I developed this hypothesis while keeping in mind that teenage pregnancies are a mediating variable in this relationship. For the qualitative portion of my research, I interviewed sexual health advocates and women that became pregnant as a teenager. To remain objective, I interviewed both comprehensive sexuality education advocates and abstinence education advocates. For the quantitative portion of my research, I used the AdHealth Public Use Dataset. This is a longitudinal study that includes 3 waves. For the purpose of my research, I used Wave 1, which includes interviews with adolescents in 1994 through 1996, and Wave 3, which includes Wave 1 respondents re-interviewed in August 2001 through April 2002, and at that time they were 18 to 26 years old. I interviewed 2 advocates from the Illinois Coalition of Adolescent Health and 2 advocates for the Illinois Maternal and Child Health Coalition. The primary purpose of this interview was to determine the reasoning behind the respondents' support for a particular kind of sex education. I asked a total of 15 base questions and also asked some follow-up questions when I felt that it was appropriate. These questions included: what type of sex education did the advocate support? Why did they support it? What type of sex education did they receive in the past? What type of work have they done to advocate for this type of sex education? And where they received the information that supports their views. I asked the same questions to both the comprehensive sex education advocates and the abstinence education advocates. There were a few common themes for each group that I interviewed. I found that when I was interviewing the advocates for comprehensive sex education, most of them had received inaccurate sex education when they were younger. They are still fairly young, in their 20s to 30s, and most of them do not have children, and one had a very young child. When asking what type of sex education they support and why they support it, they heavily stressed that it needed to be age-appropriate and medically accurate. They emphasize that this does not necessarily mean teaching very young children about condoms or contraceptives, but teaching younger children about good touch, bad touch, how to avoid strangers, or teaching older children about high STI rates and how to prevent them. Further, they discussed the importance of learning about healthy relationships, such as discussing dating violence and how to talk to your partner, whether that be saying no, or how to use contraceptives together. When I asked the advocates about the long-term negative effects for teenagers that do not receive comprehensive sex education, all of them stressed that shame was the biggest issue. The advocates stated that sexual urges are completely natural, but abstinence programs are teaching them to feel ashamed of the urges that they have, as well as not understand their bodies or orientation. One of the advocates specifically stated that she was a queer woman of color, and her sex education classes growing up just confused her further about her sexual orientation. Some schools have even gone so far as to prohibit the word gay from being used in sex education courses. Additionally, young women may continue to not understand their body as they become an adult. For instance, one advocate explained that many women that become pregnant under the age of 20 have very resilient bodies as teenagers, so even if they do drugs and they drink, sometimes their babies will come out healthy. Without the knowledge and tools to practice safe sex after the age of 20, some of these women that had children as a teenager continue to have children while treating their body poorly. As a result, their later children are more likely to have negative health outcomes. I asked the same questions for the abstinence education advocates. I interviewed one purity educator, as well as an advocate from Presence Health. Both women that I interviewed had the personal belief that children should be taught abstinence only until marriage, yet they advocate for abstinence-based. To them, the reason that abstinence is important is because it emphasizes responsibility, purity, and respect. These advocates also received little to no sex education, similarly to the comprehensive sex education advocate. However, both of these advocates were significantly older, in roughly their 50s to 60s, and have adult children. Both advocates discussed how important that they think it is that youth learn how to have a very personal and healthy relationship with their partner, which includes respecting each other and accepting no for an answer. The advocates stated that having sex as a teenager gets in the way of long-range goals, which include getting married. One advocate stated that condoms don't work and that teenagers just need to be taught to abstain from sexual behaviors. Due to the common sample population needed for our separate research projects, women that became pregnant in high school or prior to the age of 20 years old, my classmate Amy and I developed a joint interview that would satisfy the qualitative research needed for our individual research projects. Amy and I individually interviewed several former teen mothers and shared our results with each other so that we could analyze them and determine what the common themes were relevant to our individual projects. This interview included questions about their first pregnancy, as well as what type of access they had to health care and sex education at the time of their first pregnancy. For the purpose of my project specifically, we also asked them if they had received any financial assistance from a government program, excluding student loans. We found that most of these former teen mothers received either abstinence-based, abstinence-only until marriage sex education, or no formal sex education. Some of the women that did receive sex education did not receive it until after they became pregnant. Not surprisingly, these pregnancies were not planned, and most of the women did not have access to birth control or condoms. Some of them did, but were too embarrassed to go to any place like a free clinic or Planned Parenthood out of concern of the social stigma that comes with it. A majority of the women were 15 to 16 years old when they first became pregnant, and only one first pregnancy ended in abortion. However, that respondent still did have a child prior to the age of 20. Most of the respondents made little to no mention of the father of their first child, and only a couple of the women were still with the father. Though some women claim that they were young and stupid, or maybe making bad decisions when they were younger in general, A few of them said that having a child prior to the age of 20 helped them straighten up. Most of the women received some form of financial assistance from government programs, including TANF, WIC, food stamps, and Medicaid. However, we noticed a generational difference with women that are currently in their 20s to early 30s having a higher chance of receiving some form of government assistance than the women that are currently middle-aged. Since the dataset I use does not ask a specific question about sex education to the respondents, I am using variables from a knowledge quiz that confirms what they do and do not know about sex. Many of the respondents answered these questions incorrectly, or only answered a few of the questions correctly. The majority of the respondents answered about 5 to 8 questions correctly, and very few answered all 10 questions correctly. I also looked at how many respondents reported that they are knowledgeable about condoms versus how many condom questions they answered correctly. Only about half of the people that answered all 5 condom questions correctly felt confident that they were knowledgeable about condoms, while people that answered fewer condom questions correctly felt rather confident, with a rate of about 48 to 67% of confidence that they're knowledgeable about condoms. The percent of respondents that learned about AIDS and pregnancy in school is very similar to the valid percent of respondents that answered a set number of questions correctly from the knowledge quiz. This may mean that the students learned those answers from their sex education programs in school. Though the data set asked very valuable questions to my project, unfortunately there are not a significant number of people on some sort of government assistance program to really be able to tell if it does relate to the sex education programs. Since my percentage of respondents receiving some form of government assistance is very small, my multiple regression does not tell me much about what impacts the receipt of government assistance. Education level appears to be significant, and unfortunately I was not able to use race in my multiple regression at this time because the races were all broken up into separate variables. For my final paper, I will combine the races into one variable so I can see if that has a significant impact on the receipt of government assistance. Since my data set did not include many respondents that were on some form of government assistance, I found my qualitative method and my literature review to be more useful in determining if sex education impacts the receipt of government assistance. Between my interviews with teen mothers as well as the authors I read for my literature review, it appears that there is a higher and younger teen pregnancy rate with abstinence programs. I also found that most of these teen mothers had a lack of access to knowledge or resources about contraceptives or preventing diseases or pregnancy. Also, I noted that for some reason they did not find the fathers were responsible for their pregnancies and took full responsibility for getting pregnant. Though my quantitative data did not indicate a relation between receiving government assistance and sex education, I found my interviews with former teen mothers to be very informative, and most of them received abstinence-based education and later received financial assistance from government programs. Based on my research, I expect that providing comprehensive sex education can potentially decrease federal and state spending on government assistance programs. If we equip adolescents with the knowledge and resources they need to avoid becoming teenage parents, then they will less likely require government assistance in the future.